good, Declan. How are you?
I'm good. I'm very happy to be here doing another one of our China GU Cast podcasts.
Yeah, they've been very popular and I've really enjoyed doing them. It's not just these podcasts, but also the conference highlights that we've been doing. So we're very grateful for China Bayer's support, and it's wonderful to be here.
Yeah, so this is the third of our special China GU Cast podcast with the support of our gold partners, Bayer in China. And the idea behind this is we want to engage with some of our Chinese colleagues in China, because we know we have a lot of listeners and viewers there. And of course, GU Oncology, prostate cancer in particular, is now a very big growing cancer in China. And we know that clinicians in China are very interested in hearing about the latest updates. So our idea for today's podcast is to review the prostate cancer highlights from the recent ESMO meeting. And we'll be introducing our China editor, Yao Zhu, in a few moments, and two special guests who are joining us on the podcast. But before we do that, Renu, we were at ESMO together.
Yes, GU Cast did go on tour. We were at ERAS and then ESMO.
Yes, and it was a very enjoyable ESMO. It was a big meeting for prostate cancer and bladder cancer.
Exciting for GU Oncology all in all, but lots for prostate cancer.
Yeah, so much, in fact, that in a half an hour podcast, we can't cover everything. And there were some big highlights. So what we've decided this evening is to have picked three of the most exciting trials that were presented at ESMO about prostate cancer. And we'll briefly describe these trials, and then we'll ask our panel to discuss the trials. If you want to read more about these trials, we'll put links into the show notes for the podcast. Whichever platform you're watching or listening, you'll be able to go and read a little bit more about them. But we will give some top-line summaries of these three very exciting prostate cancer trials and then discuss them with our panel.
Sounds good. Let's get straight into it.
Okay, so let's now go to China and welcome our panel. First of all, welcome back to our China editor, Professor Yao Zhu from Fudan University, Shanghai Cancer Center. Zhu, nice to see you again, my friend.
Great to see you.
Hi, Declan. Hi, Renew. Really nice to see you again. And we received information from ESMO and looking forward to the discussing with Chinese colleagues.
Every time I see you, Zhu, I'm reminded of the time you were in Melbourne and in our studio, and I always miss having you right here. So it's never as fun when you're on the screen, but at least we get to have you.
Yeah, great to meet you. Both in person or online.
And indeed, in case you are missing him in person, I'm going to go and visit him in December.
Too, yes.
And we're going to record a special GU cast in Shanghai with the support of Bayer China in December. They run a really big international GU oncology meeting there with Professor Ye Dingwai. So we're going to do a special GU cast in person from China.
That will be one not to miss.
And our two distinguished guests who are joining us this evening on the podcast as well are, first of all, Professor Shouzhen Chen from GU Hospital at Shandong University. Professor Chen, thank you very much for joining us.
Thank you.
Great to have you here on the podcast with us. And also Professor Zhenhua Liu at Sichuan University at West China Hospital. Professor Liu, thank you for joining us as well.
The honor is mine. Very nice to meet you online, Marky.
Terrific.
Very good.
Well, thank you so much. And I know the three of you are very interested in prostate cancer, and you have large prostate cancer practices in your busy hospitals in China. So we're looking forward to hearing your thoughts on the three big trials that we've picked out. The three trials we're going to speak about are, first of all, the ARASENS trial.
ARANOTE, actually.
ARANOTE, sorry.
Yes.
Yeah, update from ARASENS. ARANOTE trial, which is a randomized trial of darolutamide in the hormone-sensitive prostate cancer setting. The second will be the PEACE-3 trial, which was one of the really big trials presented at ESMO in the main presidential session, which is in the use of radium-223 in a randomized trial for mCRPC. And finally, the UpFront PSMA trial, which tested the use of lutetium PSMA in the metastatic hormone-sensitive setting.
Right here from Australia.
Yeah, that's true. And we posted a special podcast about the UpFront PSMA trial with the investigators Arun Azad and Michael Hoffman. They came into the studio.
That's right. Just released just as the Arun gave the talk.
Yes. So 3 papers with different agents, each of them very exciting, Renew. What I'll do first of all is summarize a little bit about the phase 3 ARANOTE trial. So, of course, we've all become very familiar with using AR pathway inhibitors for men with castration-resistant prostate cancer over the years. And now these agents have moved forward to metastatic hormone-sensitive prostate cancer. And darolutamide, the AR pathway inhibitor, which was tested in the ARANOTE trial, is one that we've been familiar with in the metastatic hormone-sensitive setting, but only in the so-called triplet, Renew.
That's right.
And that was
exactly. So that was the ARASENS trial that you mentioned. It was the triplet of darolutamide, ADT, and docetaxel.
But the question we all have is, well, what about if we just used darolutamide with ADT and not use docetaxel, not use the triplet? Because that seems to be what we will be doing with the other AR pathway inhibitors. So there's been a gap in the knowledge because we haven't had a randomized trial which used darolutamide with ADT. Compared with ADT on its own. So this is the ARANOTE trial. So this data was presented by our friend, Professor Fred Sad.
He's a good friend of the podcast.
Who's a urologist from Canada. And Professor Sad presented this trial in one of the big sessions at ESMO, and it was simultaneously published in the Journal of Clinical Oncology. So this is certainly a big, important randomized phase 3 trial. I'll briefly summarize the trial. It was, as I said, metastatic hormone-sensitive prostate cancer, a large international phase 3 study. The patients were randomized in a 2-to-1 format for darolutamide, 600 milligrams twice daily, with ADT, compared with ADT on its own. And the primary endpoint is radiographic progression-free survival, with overall survival and other important endpoints being secondary endpoints. At the time this is reading out, the overall survival data is not yet fully mature. So the main endpoint we wanted to look at was radiographic progression-free survival. And yes, Renew, we certainly saw a big improvement, didn't we? I think the hazard ratio was 0.54.
That's right.
Meaning that patients who received darolutamide in addition to ADT had a 46% reduction in radiographic progression-free survival. So a really positive endpoint. Other important secondary endpoints included time to castration resistance and time to pain progression, time to PSA progression, and all of these endpoints favored the darolutamide arm. Indeed, overall survival was also trending in favor of the darolutamide arm, but it's not yet a mature endpoint. So clearly, I think from an oncological point of view, we can clearly see this has met its endpoint. Adding in darolutamide to ADT without chemotherapy has significant benefits. And what about tolerability? Did we learn anything new about tolerability of darolutamide in this, Renew?
Yeah, I mean it's a well tolerated drug, and the treatment related adverse events were really quite similar between the two groups of ADT alone and ADT plus darolutamide. So it wasn't a huge extra burden to start the ARPI on top of the ADT in terms of adverse events.
So that's the summary. It was a very positive trial and was very well received at ESMO in Barcelona, and the paper has just been published, as we said, a couple of weeks ago. So Yao Zhu, we might go to you first to see what's your reaction to the ARANOTE trial?
Yes, so very nice summary of this study, and I think darolutamide is, according to my knowledge, the first anti-androgen which have both the triple treatment approach and also the double treatment approach. And what my take from the two randomized big phase 3 clinical trial is the definition of chemo fit is quite different compared to trial. In the ARASENS study, we can see about 16% of patients older than 75 years old. However, in the ARANOTE study, we see like 30% of patients older than 75 years old. Also, the performance status is poor in ARANOTE study. nearly half of the patients with ECOG performance status 1 or above. So this quite makes sense because in China, we discussed before in the previous episode, we have many older patients, more comorbidities. So ARANOTE, I think, did change our definition and treatment in these chemo-unfit patients, how to improve their survival. And another interesting point Renew just mentioned is that the severe adverse events of chemotherapy, we cannot overlook it. About 10% of patients discontinue the docetaxel treatment because of SAE. However, when we use a double treatment, the risk of discontinue according to the SAE is quite lower. So it's quite attractive to give the patients with comorbidity, older patients, and some intolerance to the docetaxel with this kind of treatment, which is survival benefiting and have a very solid clinical evidence to prolong their life. So I think ARANOTE is a very interesting study.
Yeah, it's a really good point, Zhu, that you've made, because when we don't really have any evidence to show that adding docetaxel to the doublet of RP and ADT improves survival, it's very hard to justify the extra toxicity of docetaxel, isn't it?
Yes, totally agree.
Let's ask Professor Chen what he thinks about this. Do you think Chinese doctors and patients will be happy to hear that there's a benefit of just adding the darolutamide on its own and not having to be adding docetaxel as well? I think here in Australia, we're very happy to hear this news. In China, will it be happy news for the doctors and the patients to know we don't need docetaxel?
Yes.
Yeah, of course.
Because in our clinical practice, because of the Chinese insurance policy, if I apply darolutamide to MHSPC patients, I have to combine chemotherapy. Because if I don't use chemotherapy, it is difficult to reimburse for the patients. So if I use darolutamide to MHSPC patients, I have to combine chemotherapy. The ARANOTE study may change the current situation.
Yes.
So it's really important.
As for MHSPC patients, I can use darolutamide first. Then, if the patients are old or they have many comorbidities and bad health conditions, we can use darolutamide plus ADT only. And for the patients with high volume and good ECOG score, we can add chemotherapy to darolutamide. Actually, I'm very interested in the difference between double combination therapy and triple combination therapy. I think we can compare ARANOTE study and a recent study. The ARANOTE study enrolled 71% high-volume metastatic hormone-sensitive prostate cancer patients, while in a recent study, 79% patients were high-volume. In ARANOTE study, PSA less than 0.2 nanogram per milliliter at any time during treatment occurred in 62% of darolutamide plus ADT patients. However, the results were 71% in darolutamide plus ADT plus chemotherapy patients, according to a recent study. Although the baseline of these two studies are different, I think this data may indicate that high-volume patients may benefit more by using triple combination therapy. So I think if the patients are young or the ECOG score is good and the health condition is good, if the patient with high volume metastasis, I think chemotherapy plus darolutamide plus ADT may be a good choice.
Very good.
Very good. And Professor Liu, what is the trend like in China? Do urologists manage patients with metastatic hormone-sensitive prostate cancer? Do you refer them to medical oncologists, or do you manage them together?
Yeah, thanks for asking. Actually, in China, there's very few oncologists majors in the urogenital oncologists. So I think over 95% of patients were followed up in our urologist.
Right.
So after the surgery or from the newly diagnosed patients, especially for those with metastatic hormone-sensitive prostate cancer, they were asking for the therapy strategy from their urologist. So within our center, it's a biggest center within the Western China. So the patients were relatively poor or have no sense of their health care. So there's a high portion of patients with metastatic state within our centers, and I also have advocated nearly 20% in the ARANOTE trial. And as you just mentioned, the double therapy only use the ADT at darolutamide for the patients which declined the docetaxel, and the chemotherapy was a very terrible thing for most Chinese patients, as they were intolerant with chemotherapy. And many patients have heard the doctor told them they have to do the chemotherapy, and they were very afraid of it. So I think it's a very good news for those patients, especially for the less adverse events, especially with no cognitive disorder or none of the breakout in any rash, and the patient will add to the therapy with very long, maybe 3 or 4 years or maybe longer. So I think it's a very good news for them.
Very good. And that was another important thing about the ARANOTE study, is it did recruit a lot of patients in China. And we always complain, Renew, a lot of these big international randomized trials are predominantly US and Europe and not so much in the Asia Pacific region. But the ARANOTE trial had a lot of patients from China. So we can apply the data to your patients.
Yeah.
And I agree with you. If urologists are the ones who are managing these metastatic patients, having AR pathway inhibitors is a lot more straightforward than chemotherapy. And of course, the patients don't want chemotherapy. So we're all very happy, I think, to have this paper here. And hopefully the insurance situation, as Professor Chen said, will soon change so that they recognize ARANOTE and we don't have to give the patients chemotherapy.
And that's why trials like this are so important.
Very good. Thank you so much. The next trial we want to talk about is PEACE-3.
Big study.
This was big news at ESMO, and on the podcast we did from ESMO, we interviewed Professor Gillison, Professor Silke Gillison. Renew discussed this trial with her, and it was presented in the biggest session, the presidential session, so tens of thousands of people. It was very exciting to see this paper up there with our friend.
Absolutely.
So this paper is for patients with metastatic castration-resistant prostate cancer, and patients were randomized either to receive enzalutamide or enzalutamide with radium-223 for 6 cycles. Of course, we know radium-223 for many years for patients with symptomatic mCRPC. There's been a survival benefit. But there was anxiety about using radium-223 with AR pathway inhibitors because of the ERA-223 study a few years ago, which was a randomized study where radium was added to abiraterone. And the concern about that study was not just no overall survival benefit, but there was a very, very high incidence of fractures, of skeletal events in a much higher proportion in the radium arm. So therefore, there was anxiety about adding radium to another AR pathway inhibitor like enzalutamide. So what we first of all wanted to see in this study was the overall survival and the RPFS. But second of all, we wanted to see whether there was similarly a problem with skeletal related events. So, Renu, regarding the key endpoints of rPFS and overall survival in this very large randomized trial, we were very happy to see this is a very positive study for rPFS. The hazard ratio for rPFS was 0.69, very statistically significant in favor of adding the radium. And indeed, the overall survival endpoint is mature with the same hazard ratio of 0.69. So from an oncology point of view, this is very significant.
Yeah, these are impressive results, aren't they? And for both rPFS and OS, they haven't officially reported the OS yet because of that little crossover that we see. It's a bit of a statistical dilemma. So, but the curves are diverging, and it's very encouraging to see. And so very impressive results in these patients who previously have not been treated with an ARPI. And they're randomized to Enza or to Enza plus radium. Now, the point that Silky made at the time was that it's not just the doublet of enzalutamide and radium. You're actually looking at 4 drugs in these patients. It's at the ADT, of course, is there as a background. There's enzalutamide, there's radium, and there's a bone protecting agent. And that is really important to give with radium-223. That is a lesson that's been learned.
And that was the lesson that was learned. So at the start of the trial, they had not specified bone protecting agents because the ERA-223 trial hadn't read out. But when ERA-223 read out, they changed the protocol and mandated all patients must receive bone protecting agents. So thankfully, what that showed is that there is no difference. There is no increased rate of skeletal events by adding the radium, provided you add the bone protecting agent. So that was necessary. Yeah. And a lot of patients got hypertension. That's the other point with enzalutamide. So this paper was very well received, very positive. It is practice changing. But a couple of comments from the experts were, first of all, this is a patient population who had not received AR pathway inhibitor for hormone-sensitive disease because that didn't exist. So they were now castration resistant and receiving an ARPI for the first time. That was enzalutamide. And of course, as we just talked about, we now see that patients are getting ARPIs in the first line setting. In
fact, it's become standard of care, hasn't it? It's changed for prostate cancer.
And if you have received an ARPI in the first line, Renew, and then you become castration resistant, this trial doesn't apply to you then. We don't have data to say adding in the radium at that point it makes a difference because these are patients who are only receiving ARPI for the first time. So look, for some years to come, we will still have those patients who have not seen an ARPI yet, but it increasingly will be a shrinking population. But nonetheless, this will appear in guidelines and it will be practice changing. So Yao Zhu, what is your interpretation of the PEACE-3 study?
Yeah, so I totally agree that PEACE-3 is a very positive trial with both rPFS and OS endpoint meet. It's not so common in mCRPC setting. We know a lot of studies, they only achieve the rPFS, but failed the OS endpoint. So we are glad to have a GU study in the presidential session in ESMO. It's quite attractive. And I also see PEACE-3 as a start of how we can combine radioligand therapy with the active drug in mCRPC, because we next study we are discussing about the lutetium, and I think lutetium PSMA radioligand therapy is may have bright future in the near if we have strong evidence to suggest such kind of combination. And also from PEACE-3, I think the devil is in the detail, because we have not so good data from radium-223 combined with abiraterone without bone protecting agents. We see an increased risk of fracture. However, if we can take all the 4 drugs you mentioned before, radium-223, ADT, bone protecting agents, and enzalutamide, we have these 4 kind of drugs. We can decrease the risk of progression and do not increase the risk of fracture. So this is quite important when we manage our patients. Although the situation of de novo mCRPC is different in nowadays, we still have some patients with recurrent metastatic HSPC treated with maybe ADT alone.
Yep.
And we can still apply the study results to this kind of patient. And I think it will prolong the survival of these patients and quite promising.
I agree. And here in Australia, we don't have much access to radium-223 at the moment. I suppose it might change. But Professor Chen, in China, are you aware, is there access to radium-223? Is it used already for more advanced CRPC? And would you like to see it being used in this earlier setting?
Actually, in our center, radium-223 is seldomly used in first line.
Yeah.
It is generally used as second line or third line or end line in treatment of mCRPC. I think maybe one reason is the previous ERA-223 study showed a high fracture risk with abiraterone combined with radium-223. So I think the PIS3 study changed the current first-line treatment for mCRPC.
Yeah.
But we should pay attention to use the bone protecting agents. I think maybe the increased fracture risk by combination of abiraterone and radium-223 may be due to the application of prednisone and less use of bone protecting agents. So anti-androgens are the new generation anti-androgens combined with radium-223 may be a confident combination for mCRPC.
Very good. And I suppose, Professor Liu, another consideration is, I think 20% of the patients in this study did get docetaxel up front. So although none of them, well, only a tiny number got an ARPI up front, we could apply this data to patients in recent years who got ADT and docetaxel for hormone-sensitive prostate cancer and now become castration resistant. So I'm sure we will all see some of those patients that we've given docetaxel to in the last 5 or 6 years in hormone-sensitive disease and possibly getting radium. What do you think?
I think the docetaxel, which is the chemotherapy, will have a very obviously myelosuppression effect for them, and within the neuro hormone therapy agents, which is not. So I think the newly CRPC patient, which was using the new ARI for the first line therapy, had the more tolerance for the radio pharmacies. And since the radionuclide therapy is a very newly aspect for the developing the new therapy strategies for the prostate cancer, especially the result of the PIS3 study carry significantly clinical implications for them. And the previous safety study data has already shown that the radio-223 used in the combination or for the single agent for this kind of patient is very good. And within our center, I have only 4 patients using the radio-223 for the last 2 years. And I think the only limitation for the widely used for it is the limited production capacity and the high expense. So if there's any change for the expense for the drug, I think they are very very widely used within the Chinese patient.
Very good. I totally agree. I think those two barriers of logistics and production, it's even worse trying to get it all the way to Australia and also cost. But this data hopefully will spark some interest in industry and in the funders and the regulators to try and overcome those barriers, because clearly some patients will benefit. Renew. I thought radium was gone, but no, it's clearly big news.
Yeah, and I mean, I think that's the thing about all these treatments and treatment combinations that we see in these trials. I mean, there's probably a place for them. It's figuring out where to use it in the sequence of therapies for prostate cancer, and we're seeing patients not just in different stages, but who've had different backgrounds of treatment as well. And the next paper we'll talk about, which focuses on lutetium PSMA. In fact, I mean, lutetium PSMA and other radioligand therapies is actually very different to radium-223. I mean, lutetium's a targeted therapy, whereas radium-223 is almost like a bone annihilating agent. Yeah. And that's why it's very good for those bone-sheltered metastases. It works in a different way. So I there's a role for it.
Yeah,
where it fits, it's not quite clear, but there's a role, there's activity.
It is exciting. So our final paper is, of course, the exciting area, again, of radioligand therapy using PSMA. This is the UpFront PSMA trial, a randomized phase 2 study. So these were newly diagnosed high-volume metastatic hormone-sensitive patients, and they were randomized to either have ADT and docetaxel, because that was the standard of care at the time we started this study after CHARTED, or ADT, docetaxel, and 2 cycles of lutetium PSMA 617, the Novartis compound, the same one we used in the therapy trial and in the lutectomy trial. And this was led by our colleagues at Peter MacCallum Cancer Centre, Arun Azad and Michael Hoffman, a multi-centre trial running across Australia of 130 patients. So this is a small phase 2 trial, not a large trial, but this is the first randomized trial to describe the impact of adding in lutetium to standard of care treatment in metastatic hormone-sensitive prostate cancer. So I suppose for that reason, it did have a lot of interest. It was in it was in the oral session, so it was in a very significant session presented by Arun, and it was also published in Lancet Oncology at the same time. So the paper is already out. So the primary endpoint in this study was undetectable PSA, defined as a PSA of less than 0.2 at 48 weeks. So not a classic oncology endpoint like RPFS or overall survival, but that was the nature of it as a phase 2 study with shorter follow-up. And it was a very, very positive endpoint that was reached. So in patients who had received the combination of lutetium PSMA, docetaxel and ADT, the undetectable rate was 41% of patients, compared with only 16% of patients who received ADT and docetaxel. And that similarly translated into favorable radiographic progression-free survival, and quality of life and pain scores were also very well maintained. So certainly our conclusion, and we, as I said, we did a separate podcast with Michael and Arun where we went into great detail on this just a few weeks ago. Certainly signs of efficacy by adding in lutetium, at least in these endpoints. And thankfully, no extra toxicity or burden for patients, despite the fact you're adding an extra treatment. And Arun's thoughts are the toxicity is coming from the ADT and the docetaxel. Adding in lutetium doesn't really make much difference. I think
I mean it's such a great study, isn't it? And very interesting. And I think the one thing that we've seen from using lutetium PSMA in the end stage setting, in the MCRPC setting, and even in the lutectomy trial upfront setting, is that it's very well tolerated. And not only is it very well tolerated, it in fact lends itself to improvements in quality of life and symptom management. So we've seen that. So it's really reassuring to see that it doesn't add any toxicity to this combination. And I think the time to undetectable PSA is a good endpoint, because we know that those patients who reach a deep, fast response when it comes to PSA do better. And this is a significant improvement with the addition of lutetium PSMA.
And we've seen that in the RP metastatic hormone-sensitive trials. But we'll be careful to say it's not a practice-changing trial. Arun is careful to say that, because this is still an endpoint we wouldn't accept. And but it got people excited because there is a big phase 3 randomized trial coming, the PSMA addition trial, which is using ADT and ARPs plus
Six cycles
of
lutetium
lutetium.
PSMA.
But we'll have to wait another year or two probably for that. But this certainly gives us some encouragement. So, Zhu, you have a big interest in PSMA radioligand therapy. You've been down here a few times to visit us. So what are your thoughts on UpFront PSMA? And indeed, you know the authors quite well.
All of them, yeah.
Yeah. Yes, I'm very happy to see the data come from the UpFront to give a lot of information, especially in HPC setting about the lutetium combined with docetaxel. And I compare the UpFront PSMA study with therapy study, and I both use the PSMA and FDG PET to stratify and select best candidates for the lutetium combined with another active drug. However, in mCRPC, we have like 17% of patients with discordant disease and around 10% of patients with low PSMA uptake. However, in HSPC, very few patients with discordant disease, about 10% of patients with low uptake of PSMA. So this is, in my opinion, a strong signal to move lutetium PSMA upfront. So this is one implication to me. If we can apply this kind of radioligand therapy in an early phase of prostate cancer with less heterogeneous disease and combined with maybe another anti-androgen, which we see in the NRP trial, and I think it may have a great change to the current status of treatment. So we have some lutetium PSMA patients in our center in end-stage setting, and we are looking forward to do some preliminary clinical trial in early stage to test this kind of hypothesis. And we also very glad to see our friends in Peter Mac to do such wonderful study and bring a lot of information to me.
I think he's made a really good point, hasn't he? Because you're right, Zhu. I think when you get these patients, in the newly diagnosed hormone-sensitive setting, you see less heterogeneity, and you see a lot more of that in the mCRPC setting, where not all of these lesions express PSMA, and so you're a bit more limited in your ability to use lutetium PSMA in these patients. Like us, you also believe in doing these imaging studies to select for patients, both FDG PET and PSMA PET, and you really do get a wealth of information from that.
And there will be a lot of scan data coming out of this, because these patients are getting not just baseline FDG PSMA, but also they're getting routine scans at a couple of months later. So we'll get a lot of data about what does lutetium and ADT do to these scans, Professor Chen, what are your thoughts on moving lutetium into this earlier disease setting?
I think the lutetium as nuclear drugs are usually used in mCRPC, but this study UpFront PSMA is the first randomized study in MHSPC, and I have an initial idea in UpFront PSMA study. After the patient received lutetium and chemotherapy, they are treated by ADT alone. So I think if we can add some androgen receptor pathway inhibitors, such as darolutamide to lutetium followed by docetaxel in very high volume patients, maybe I think the oncological results will be better and no additional adverse events. So in China, currently in our center, lutetium is not accessible, and I lack some relevant experience for the application of lutetium. But soon we will able to apply lutetium. I think nuclear drugs will occupy a very important position in treatment of prostate cancer. Thank you.
Yeah,
Very
I agree.
nice.
And we understand that when you're bringing in radioligand therapy, it's different to just adding an AR pathway inhibitor. You need a different type of infrastructure in your hospital and staff and radiopharmacists and nuclear medicine people and technologists. So it is quite a challenge, and especially if it's a common cancer like prostate cancer. So we understand that. But hopefully, like we discussed with the radium, if people see these benefits, we will see better access, at least for the CRPC patients where there's clearly a benefit. But yeah, and Professor Liu, you for the last thoughts on lutetium PSMA upfront.
Yeah, thanks for calling. Actually, in recent years, there has been a continuous stream of advances in the radioligand therapy, which has covered multiple lines of the treatment for the metastatic CRPC, including the Vision trial, the PSMA4 trial, or the INTA-P trial, and of course, including the PSMA upfronting trial. And I've noticed that the primary endpoint was the rate of the undetectable PSA level, which is very important for the patient within China. And the results show that the sequential treatment with glutamate followed by the docetaxel significantly improved the rate of the undetectable PSA level. And I think the early use is, especially the upfront use for the radioligand therapy, will help the patient, as the use of the AR inhibitor may cause prostate cancer into the neuroendocrine carcinoma, which is lack of the expression of the PSMA. And we also find there's a lot of the newly radioligand therapy pipeline in China, including the lutetium, and also for the alpha radiodecade, the actinium-225, which is mainly for the alpha decade for 6 times. And I've heard I've read some news that the lutetium may cause some off-target organ side effect, including the renal failure or some other things. And I think the radioligand using the alpha decay may helps to reduce the side effect, and it has a very popular future for the patient therapy. Thanks.
Well, that's one of our favorite topics, talking about the future of radioligand therapy. And I think you're completely right. Using alphas like actinium-225 or terbium. We've just finished recruiting a trial using terbium, which is an alpha emitter, and Auger. And we have a trial combining alpha emitter and beta emitter, radium and lutetium. So this is just the start, I think, of the whole radioligand.
And combining lutetium and cabazitaxel for exactly that population that Zhu was talking about, the ones who have discordant disease.
So exciting times.
Yeah.
So that's it, Renu. That's 3 exciting papers. And I must say I was very impressed with the expert comments from our friends in China. I learned a lot from this.
Absolutely.
And I think we're all very excited to see these papers coming in. Professor Zhu, Professor Chen, Professor Liu, thank you very much for taking the time to join us on this special Bayer China episode of GU Cast. And I'm sure our audiences in China will be very happy to hear these conversations.
Yes, we've had a great time.
Thank you. We have a very good time.
I learned a lot from you, and we look forward to the next one, don't we, Declan?
We sure do. So that's all we have time for on this episode of GU Cast, one of our China specials. Thanks again to our friends at Bayer China for being gold partners and helping us put together these special episodes for China, which of course the rest of our global audience also enjoy listening to.
And you really do help us get the conference highlights to the whole GU community, which I think is fantastic.
Yeah, we love that. So we love being here in the studio, but we love when we get out and about and go to conferences and meet friends and bring you scientific highlights. And that's also thanks to Bayer China, who support the conference highlights. And we will be back with our normal GU cast in a few days' time, but I'm very excited to be bringing our fourth special China episode in December when I visit Shanghai. I'm rubbing it into you.
In China itself, he's really missing out. So and Renew, you can't have too much fun.
Renew is not coming because she's at ESMO Asia in Singapore the same weekend. Yeah. So I tried to convince her to come to Shanghai, but she's on the scientific committee of ESMO Asia.
So I couldn't. Not this year.
Yes, but we'll be thinking of you in Shanghai. So that's all we have time for on this special episode. Once again, please do search GU Cast and please subscribe wherever you get your podcasts, on audio channels or video channels, and please do leave us a rating, and we love hearing from you. So if you have things you want us to talk about on GU Cast about GU Oncology, please do get in touch.
Let us know.
Thank you so much.
Bye.